Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health.
Hello again, everyone, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and today I am sitting down with Dr. Gaddiel Rios, a primary care physician in Rapid City who's part of a national network that's called MDVIP. It's a different way of practicing medicine, smaller patient loads, longer appointments, and a real focus on catching problems before they become problems. Dr. Rios is going to walk us through what kind of care this is and what it looks like, who's a good fit for it, and why preventative medicine matters more than most of us realize. Welcome, Dr. Rios. Thank you for coming in.
Well, thank you. Thank you for having me here.
Now, how long have you been here in Rapid City?
So in Rapid City, we opened the clinic last summer. So actually today's the 1 year mark.
Oh, congratulations.
So before that, I was in South Dakota as the Associate Chief of Primary Care for the Black Hills VA.
Okay.
And so total a little bit over 2 years in South Dakota and about 2.5 years in Wyoming before that.
Well, where do you come from before you ended up out here in the middle of nowhere?
So I have a very nomadic trajectory.
Yes, that sounds like it.
So originally, my folks are from Puerto Rico.
Okay.
And so we moved to Massachusetts when I was 7, where I went to school, high school. Did my undergrad in Michigan at Andrews University, and then medical school at Tufts University in Boston, Massachusetts. I took the military health scholarship at that point to help pay the bills. So I traveled with the U.S. Army from Walter Reed to Belgium, Fort Hood, Texas, Fort Polk, Louisiana. I got a year's vacation in Iraq, 03 and 04. So I like to say, sun, sand, palm trees.
I mean, that's how you got to rationalize that, absolutely.
Yeah. And then in 05, I opened a private practice in Houston, Texas.
So you were enlisted?
I was an officer.
You were an officer. Okay, got it. Yep. Okay.
Yep. One of the nice things about the health scholarship the U.S. military offers, because you can be in any branch, and so Army, Navy, Air Force, so forth. You come in as a medical officer, so you go from, while you're in school, you're a second lieutenant, and then once you graduate, you jump from second lieutenant to captain and full active duty. And so my time in the military was always as a medical officer.
Oh, okay.
And so that was from 94 to December of 05. Yep.
Did you always know that this is what you wanted? I mean, when you moved over here, do you have it in your family background? Is there medicine?
So my youngest uncle, the last in my mom's side of the family, he's about 9 years ahead of me. So he was the first one to go to college in the family, and so he went through medical school the same way with the health professional scholarship. And so he was in the military. And so when I was in high school, that would have been when he was graduating from medical school. So he served as a role model, for me. Now, with that said, through high school, my intentions were not medicine. I actually spent 3 summers at IBM camps in the 80s, learning computers. And, in the early 80s, that was sci-fi.
Oh, right? It totally was.
So it was exciting. It was neat to be part of the summer programs, with the IBM group, learning about cutting-edge technology, which back then was, refrigerator-size systems. So it was really exciting in the we're talking 83, 85 time frame. It was really exciting. But then in 86, one of my teachers, I think it was my biology teacher, put me in, recommended me for a summer program at UMass Medical School for high school kids that were science, interested in science. And I spent 6 weeks at UMass, rotating with medical students and residents and seeing the hospital. And that's when I fell in love with it, because even though I loved computers and I loved science and math, the difference was the interaction, being able to talk to someone and be there and help them out. So when I went off to college, instead of following engineering, which I had been offered a scholarship at Boston University for that, I did a bachelor's in medical technology that took me right into the hospital system. And that led me to a couple of years at the Cleveland Clinic in Ohio, where I ran a research department under Dr. Eric Topol. And that was my kind of stepping stone to medical school. And so that was my trajectory.
Boy, that's a long road to get to where you are right now, for sure.
Yeah.
But I mean, it sounds like you had a genuine interest in this, and it seems like so many of the doctors I talk to on here, it's not immediately known, but something about getting into this profession, it clicks for them.
Right.
And then that's, they're like, this is it for sure.
Yeah. That's how it was for me. That summer I spent at UMass was like, wow, this is really what I want to do. So,
well, let's talk a little bit about now while you're here, Doctor, about this specifically, because this was one of the doctors I had talked to a couple of years ago here on the podcast had brought this up, or maybe a year ago, and I didn't really look too much into it after the fact until I got the topic that you wanted to talk about, and this is I'll just get into the acronym of MDVIP. It's a name a lot of folks I don't think are familiar with at all. So give us just kind of a quick overview of what it is and how your practice kind of fits into that network.
Yeah. So the company has become a national company. They've been around since 2000. Started off in Florida. Basically a group of primary care doctors in the year 2000 looking ahead saying, where's healthcare going? And a lot of doctors, especially those of us that are a little bit older, that saw what medicine was like, seeing what medicine has become. So they predicted that back in 2000, and so they got together and said, how can we provide a system that still allows direct care with the patients, direct access to your doctor, time, and quality? And so they went to D.C., started doing all the homework, looking at where legislation was going, how they can, get this off the ground. And the reality for them was that, not pure concierge medicine where you pay for everything along the way, but a membership-based to offset the cost of the volume, right? So when I was in Houston, for example, my patient panel in Houston in my private practice was 4,000 patients, right? Because you have to see patients, you have to have the flow to pay the bills, and that's just a reality of modern medicine. So with the model with MDVIP is, can you keep the patient load between 400 and 600 patients? That way you have the time that I can sit down for an hour and 15 minutes with a patient if I need to, where I can walk in patients every day if they need to, or at least see them tomorrow, and have the accessibility. The other really important aspect of it is that every one of my members gets my cell phone number. And so they know they have access to me. They can talk to me. They can call me if something happens. It's not leave a message somewhere or put in a computer message and see when it gets responded to. So when you look at it, it's accessibility. So you have access to your provider. It's availability. It's not, we can see you in 2 weeks or 3 weeks. It's we can see you today or tomorrow. So those are two big aspects of it. The other thing they were aiming at was prevention in terms of cardiovascular disease. So when I was at the Cleveland Clinic, our focus was on all these heart attacks and how do we open up the coronary arteries and how do we prevent clots and use platelet inhibitors. And so that was in the early 90s. You look at the statistics in the United States and you look at the amount of cardiovascular disease, my goodness, it's overwhelming. So one of the focuses is how do we lower that? So nationally, if you're an MDVIP member, there's a 12% lower risk of a heart attack. Now, when you look at the impact of 12%, that's a huge impact, right? And so by allowing us to do extra tests that normally don't get paid for with regular insurance, we incorporate that into the membership fee, then we can take a deeper dive and look at coronary artery prevention. So let's reduce the incidence of heart attacks, of strokes. The extension of that is wellness and living better, healthier, longer. And so it's a combination of the lifestyle, the dietary changes, and do we know our numbers? What can we measure and help fix?
Well, what just stands out to me, you said at one point 4,000 patients. Now you're down to 400 to 600.
Right.
I mean, that alone not only gives the patient you're seeing a peace of mind, but boy, for you, it also has to feel fantastic.
Sure. I mean, my average day in Houston was 32, 33 patients in a day. And so when you convert that to now 8 to 10 patients in a day,
Yeah.
and that's a busy day, you have time. You have the time. And so it makes a big difference.
Well, and you were talking about the screenings that you're able to do. I believe with like an MDVIP, the wellness program includes what you guys consider advanced screenings,
Right.
that kind of go beyond what insurance will even take care of. Correct?
Sure.
What does that mean?
So there's a few markers when we look at so irregular annual wellness includes a cholesterol panel, right? Cholesterol, triglycerides, HDL, LDL. What we can do is we can look beyond that and say, well, the submarkers like apolipoprotein B, lipoprotein A, myeloperoxidase, LPPLA2 activity, these are cardiac markers that can give us a better insight and a better predictor of what your actual risk is beyond just looking at your cholesterol. So that's just one aspect of it. Most insurances won't pay for that. And so that's paid for with a membership fee. So it's inclusive of the membership fee. There's no extra fees for the 2 executive exam visits that come with it, and it's all inclusive. So beyond that, we do a screen EKG, pulmonary function test, grip strength, blood pressure comparisons of arms and legs. That's called an ABI. We do a body composition analysis, hearing, visual. So we really bundle up a lot of screening tools that normally don't happen in a regular visit that can allow us to take a deeper dive.
One of the stats I saw too in looking into this that kind of stood out to me, 72% lower hospitalization rate. Is that accurate?
Well, it is, because this is what happens, right? And anyone in healthcare will tell you, especially the ER will tell you.
Yes.
I don't have access to my doctor, I'm going to go to the ER, right? Or I wasn't able to see my doctor, now what I had worsened, now I have to go to the ER. When you're accessible and when you can see your doc, you can catch those things early, treat them and manage them in the clinic and at home, as opposed to waiting for the complications to evolve, and now you have to go to the hospital. So that's part of it. The security, I can't tell you how often in different areas that I've been, because I practice in a lot of different areas,
Right.
that people's go-to is the ER for whatever, right? And so all of a sudden, I have an earache. I don't have to go to the ER or acute care. I can visit my primary care doctor. Or I sprain my ankle on the path.
Right.
I can see my primary care doctor. I've had people that have slipped and fall and need suturing. Well, let's do it in the office.
Yes.
We can take care of that. You don't necessarily have to go to the hospital for those things. So it really evolves into a situation where all of a sudden now you don't have to worry about the hours you're going to spend going to the hospital, and the hospital doesn't have to carry the burden of things that could be done in the family practice office or the primary care office. Yeah, so it's impressive.
But you say that you give your cell phone number to these patients.
Yeah.
That's a 24/7 commitment right there.
Yes, it is.
How do you handle something like that?
Well, let me frame it with, I did the same thing in Houston with 4,000 patients. And the reality is that when patients know that you're accessible and know you're available, if you get a phone call, if they call you, it's significant. I want to talk to those patients.
That's a good point.
Now that does take time, and it takes commitment from the provider, from my point of view.
Right.
But the reality is, even with the volume of patients I had very few phone calls, at night or the weekends. And when I did have those phone calls, they were important. Same thing here. So we just hit the year mark here. And yes, when my patients text me, message me, call me, it's important.
Yeah.
And so I don't mind answering those things. And when patients know that you're accessible and you're there for them, it doesn't get abused in general.
And I wonder too if that, knowing that is there, gives you a peace of mind to where maybe you don't have to call it. I know he's there. I know he's available. And maybe maybe I can wait until tomorrow morning.
Sure.
Maybe I can do, because I know that I'll get a response.
Yeah.
Maybe that plays into it a little too.
It does. It does. It gives them a peace of mind that they
for
know
sure.
that, I don't have to overstress about this. And nowadays, of course, simple text message
Yeah.
goes a long way. And, I get text messages. Sure, I can reply to that and say, oh, yeah, you know what, let's talk about it. Or, oh, no, you're fine. Come in the morning and I'll see you. So I think having that level of communication goes a long way.
Yeah.
Because it's frustrating. If you ask people in this market, because we're in Rapid City now, how easy is it to talk to your primary care doc? Well, I have to leave a message. I have to send a computer message. Eventually someone replies to that. It's not the doctor. And so it creates a level of frustration and then uncertainty. Because am I getting the right answer, right? And I don't mean to be critical of the system.
Of course.
It is the way it is. And these measures are put in place, to help communicate, with the patients. But the old-fashioned way of having accessibility to your doc, I think that goes a long way. I mean, early on in my career, I was in Houston a long time. And my goodness, I got invited to birthday parties, to weddings. I actually had a few patients that left in their will that I had to speak at the funeral. And so I 3 that come to mind that are very memorable that I went and did their eulogies. Not that that's something I want to do.
No, that's the last thing you want to do.
But it shows the amount of relationship that you've been able to develop with these folks that, now they hit their 80s and so forth, and they want you to be part of, you've been part of their lives for 10, 15 years. They want you there as well at the end. And it goes to show the relationship that you can establish.
Well, in talking about relationships like that, it must be hard for you to leave certain places then when you've built these relationships too. I mean, that'd be challenging.
Yeah. So part of it was automatic because of my military time.
Yep, right.
You just had to pick up and you went on. I spent a long time in Houston. And so, really the bulk of beginning of 06 to 2021, that was tough to make that decision. Now, part of it was not my choice. We had a huge freeze in 2021. Overnight, it destroyed my building and my practice. And so you wake up the next morning and you realize, I've lost everything.
Yeah.
And so what do we do next?
Well, you go to a place where we can handle freezes pretty good.
Right. Yeah. Yeah, I don't have to worry about PVC pipes and copper pipes and no insulation. So
that's right.
So that was hard making that decision. Now, I came up here with a specific goal, which was to build a rural clinic in Wyoming near Devil's Tower. And then that's when I took the role of Associate Chief of Primary Care for the Black Hills VA because of my time as a physician, you start getting more to the administrative side of things. And so I was heading down that administrative road of being, a chief, associate chief, eventual chief medical officer, things like that. But very quickly realized that I really miss my patient interactions, which is what got me into medicine to begin with. And so when I had a conversation with our CEO, Ms. Davidson, and she presented this, this plan that they've been thinking about, and that really kind of lit the light bulb and said, you know what, I would love to participate in that, be able to give care one-on-one with time, give the quality. So that's how this particular journey started. So yeah.
Well, let's talk a little bit about, because this is people probably have picked up on this now. This is a membership-based service is what this is.
Yes.
So let's kind of talk about who this is really for in a way.
Yeah.
Some folks will hear membership-based care and assume it's only for one type of person. But who tends to benefit from something like this?
Sure. Well, it's interesting. My current age distribution goes from mid-20s to 80s. So it's a pretty wide range. And so when you look at that, every age group is looking for something different. So the younger age group are looking for, how do I live better, healthier, longer, and how do I plan ahead because of whatever moves them that way, family history, friends. The middle of the group, so your 40 to 60-year-olds, they're getting to that phase of life where they're looking at, how am I going to enjoy my retirement, right? And how do I stay healthier? And then the over 60 population, which had the old-fashioned way of medicine, now they're like, well, how do I get that doctor that I can really talk to and see me when I need to be seen, because now I have more health issues and concerns. And so that's kind of how I break up those three age groups in terms of what they're looking for. Besides that, the executive exam is something that people like because we can dedicate to a deeper dive. The first visit for the executive exam is about an hour and a half. The follow-up visit, where I sit down and I customize a health journey for them with all the data we've collected, about an hour we take for that. And so that's really important for a lot of people. With the corporate side of that, then the corporations that want to take advantage of that, and there's certain benefits financially for corporations to use their benefits for the executives or their employees, keep them healthier. Mm-hmm. It translates into less missed work, better quality of work, lower cost of healthcare, because if you keep your population healthier, less usage of emergency rooms, hospitals, then when they renew their insurance plans, it's a lot better. So there's incentives there. Nationally, I was told by MDVIP nationally that a huge portion of those groups are people like nurses and truck drivers, because of accessibility.
Yeah.
The other thing is, because it's a national network, let's say I have a patient traveling to Arizona and they need to be seen. Well, instead of going to an ER or an acute care, they call me. I call one of our affiliate clinics down there and say, hey, can you see our member? And they can walk in because they're a member. And
sure.
Along with that, we have a network of 15 major medical centers that we're affiliated with. So if we need to refer to a subspecialist or something that we don't have here locally, Monument Health has a great relationship with Mayo, but now we have an extended relationship with places like Harvard and Johns Hopkins and MD Anderson and Miami and LA and UCLA and a few other places, that if we need a subspecialist somewhere, we are connected through MDVIP with those networks.
How many doctors are a part of this?
So right now it's about 1,300 doctors nationwide, and they're in 47 states.
Okay.
And about 400, I think it's now over 420,000 members in MDVIP nationwide.
Okay.
So, yeah.
Is there, this might be a weird question, kind of on the flip side, is there anyone you'd say this might not be a fit for?
Well, as a physician,
yeah,
I think everybody should have a good doctor and take care of their health.
Perfect.
Preventive.
Yeah.
Now, there are folks that, let's be honest, there are folks that they don't want to know.
Right.
They don't want to use it, right? And so for someone who is not really going to take advantage of it, they're not going to benefit from it, then why do it? Why spend the money?
Mm-hmm.
But in general, because we are primary care based, so if you look at the places that do executive exams, I think the current Fortune magazine that listed the best executive style exams have Mayo and then MDVIP right below it. But we're the only one in the top 10 that are actually primary care based. Because we're primary care based, then there isn't a reason to say, no, this doesn't apply, because I see the members, I see their children as well. That's an added benefit to having the membership. So, I see the little toddlers, I see the teenagers, up to the age of 26 as a dependent. And so because it is primary care based, it's hard to say who shouldn't benefit from it. The places that are strictly executive style exams, and they're built for executives, then that's very limited.
Yeah.
That's just for the executives, just for the high-end, CEOs and things like that.
Now, do you say you can go from like pediatrics to adult? I mean,
right. Yeah. The only thing I don't do anymore, I stopped delivering babies years ago.
Yeah.
so I don't do that anymore. But I still see toddlers, young kids, teenagers, and so really from the toddler phase up to geriatric phase.
Okay.
Now, if we need any specialist or any subspecialist or anything like that, then of course we reach out and we do those referrals as needed, obviously.
So that's how this all ties in kind of with Monument then too.
Correct.
In that sense. Okay.
Yeah.
Well, for someone who's, we're hearing this podcast right now and is interested but hesitant, what do you want them to know before they reach out to you? What would be some good questions they should ask you to know if you're the right fit?
Sure. So, first thing is, what are they looking for? Are they looking for managing their current medical problems? Yeah. Are they looking for prevention and wellness? Do they want to talk about weight loss? Do they want to talk about, preventing cancer, preventing heart attacks and strokes? And so I always like patients to come with their history, to know themselves and their family history, and say, hey, here's my history, and what are the things you think I should watch out for? What are the things we can work on? And so I always like my patients to be informed. First of all, personal knowledge, information, and then, where are we going with this? What is the purpose of this journey? Is it to just manage your medicines and let's not worry about anything else? Or is it, how do we improve our outcomes? And so that's one of the things I do with my patients. We have an AI algorithm that I use for the cardiovascular risk, and I can plug in their data, and the AI calculation stops at 80. I guess beyond 80 is bonus time. But it's a really nice tool that I've used that's powerful, because I can say, look, here's where you are today, and your risk of having an event down the road is X. Mm-hmm. But if we make these changes, then that risk is going to drop. And already, I'm able to show that with patients, and it's empowering to say, wow, I just dropped my risk of a heart attack by 20%. That's empowering. And so when I have patients come in, I want them to know, okay, where are you at from a personal family point of view? Where are we going? What are we trying to get out of this? And because, if it's just to come in and see you once a year, then probably this is not the right fit for you. The right fit would be patients that want to be engaged, they want to be involved, they want to improve their health, they want to reduce their risk down the road. Yeah. That's empowering. That's what I like to do.
Now, you mentioned an AI algorithm in there, and you going back to having the interest in technology like you did in the 80s. Do you are you amazed at how it's changed? That just the tech alone from when you started until right now. I mean, you have to look back and be like, oh my goodness.
I'm going to age myself. But, well, when I was a medical student, we had our lab coats with pockets built inside the lab coat and outside the lab coat, and you carried tons of weight on you with all these books you had to have as a reference source. The PDF, which is the book that has all the available medications to prescribe, was very thin and fit in the shirt pocket. Mm-hmm. You can't do that today with a drug book. And I'm not going to put down the drug companies. Right. So the technology has shifted from intense, I have to look that up, I have to go find it, and then you have to keep up with the journal articles and what's the new studies, to the accessibility is on your phone. Yeah. I mean, it's there. The accessibility is there. Now, the one thing I caution students with, and the mentoring I've done over the years, is that we have to be careful not to be dependent on our tools, especially AI. Mm-hmm. It's kind of a misnomer. AI is not intelligent.
Correct.
Right? AI does not make moral decisions or logical decisions the way our brain does. But AI is a great tool to condense the data, process the data, and give us a summary of that data. Mm-hmm. Recently, I had a little interaction with AI with a patient, and we asked AI on Google a question, and then we asked AI on the medical app that only uses scientific journals to answer the question, and the answers were very different.
That is just good advice to tell everybody.
Yeah, and then the other thing people don't realize, their AI answers online are dependent on their region.
Right.
So if you ask a question in South Dakota compared to Florida or California, you're going to get slightly different information. And people don't realize that.
Yeah.
AI is not some human back there making super, decisions. It's just a collection of data.
Yeah.
So whatever data gets put in the system, it's going to crunch it out.
Yeah. Well,
So-
like I said, having, you have both of those interests. You're kind of in the best of both worlds. Technology, where it's come now, getting to practice and be with people has to be, I mean, what a great trajectory for you, honestly.
Sure. No, yeah, and it's great. I love tools. I love technology. We just have to understand how to use it and what their limitations are.
100%. Well, Dr. Rios, this has been great talking to you. I'm so glad you came in and did this.
Yeah, thanks.
He's a primary care physician in Rapid City who's part of a national network called MDVIP. And you can just put into Google MDVIP or MDVIP.com, I believe is
Correct.
where it is.
Yes.
And you can get all of the details. It can link out to you and your practice here. And look it over. See if it's right for you, for sure.
Definitely.
Well, thank you very much for coming in, Doctor. I really appreciate it.
My pleasure. Thank you for having me.